getting older. Now it's getting pale and cold. And maybe this person has smoked a couple cigarettes or has had blood sugar problems in their life, and the legs starting to get achy and cold, and it doesn't seem to. Maybe it's getting a little weaker. Uh, what might that indicate?
Well, Gil, you're now moving into the arena of the majority of what we do, actually.
All right, excellent, good segue.
And that is peripheral arterial disease. And it turns out that the arteries in our body, which take the blood flow from our heart out to our tissues and organs, as you previously mentioned, are thicker and are prone, way more prone, in fact, maybe prone 100 times more than the veins to buildup of plaque. Blockages, that's exactly right. And so these arteries are prone to develop problems with blockages, with aneurysm degeneration or formation, and things like that. And as you also mentioned, the aging process predisposes us to that. Nicotine predisposes us to that. Diabetes,
high blood pressure,
high cholesterol levels, lack of a regular exercise program, hereditary components. So there are a lot of things that are risk factors for that. And interestingly, in this country, atherosclerosis is almost endemic. And it has to do with our diet, it has to do with our genetics, it has to do with our lack of regular exercise. And if you look at young individuals who are in car wrecks, who die in car wrecks and who get autopsies, you will find the early formation of plaque in arteries in individuals who are 17 and 18 years old. So it's the beginning of that whole process. And if you went to a country like China 30 to 40, 50 years ago, you would not see that even in individuals who are older. And the reason it was because their diet, very low in cholesterol. They exercise.
Well, I don't want to get too much into cholesterol because I think most of that is bullshit. But I will leave that. Okay. And I think there's a lot worse risk factors for vessels.
Well, everything in moderation. There's no question about that.
And I'm going to have whole podcasts on this subject. So I want to avoid that rabbit hole.
Okay.
But let's just say refined foods, Western behaviors, patterns are creating this.
My point is that if you visited China 50 years ago, atherosclerosis was a non-entity.
Wow.
If you visit China now, it's huge. And the reason it's huge is because they want to be westernized.
They have the Western
They want
diet.
to drive a car. They want to eat our diet. They want to smoke cigarettes. I mean, they want to do all the things that we do, and hence the.
So it's something in there.
Yeah,
right?
So
we can argue about it,
but
we can say the bird's eye view here. It's the whole thing is creating these vascular diseases and blockages. So a person is getting a blockage.
Yes.
Legs getting cold. What can you do to help this person?
Well, when someone develops a blockage, usually...
And sometimes it's slow, too. I mean, it's a partial block. It's not all of a sudden
it's almost
blocked.
Always slow.
Okay.
Now, there are some acute syndromes where you have acute blockage of a blood vessel resulting in an acute problem with the end organ, the limb, etc. But mainly we're talking about a chronic, slow process. And one of the first manifestations that as an individual you would experience would be intolerance to exercise.
And it's weak or they cramp?
Yes. So this almost always occurs in the lower extremities as opposed to the upper extremities.
I'm glad we started in the lower extremities.
Yeah. As a matter of fact, the femoral artery is the most commonly involved. The superficial femoral artery down just above the knee. At what we call the adductor hiatus, which is an anatomic differentiation between the superficial femoral artery and the popliteal artery. And there's something about that area, and this is debatable, and we're not going to get into that, but there's something about that area that causes plaque formation. And so that's the most frequent area involved. And when that's involved and you decrease the blood flow significantly you're decreasing the blood flow to the calf. And so frequently the first manifestation is that someone who could go out and get their mail at their mailbox, say 500 feet from their house, is no longer able to get back to the house in one trip.
Is it
They
usually
have,
one side? It's kind of a hint that maybe it's one side.
yes, for
Ah,
reasons that are unclear, it's usually
right.
one side.
It's not going to be equal on both legs every time.
It can be, but it's not
Right.
typically. And so they come in and they say, "Hey, I'm having a cramp in my leg. When I walk, when I stop and rest, it goes away, and then I'm able to walk again for another, say, 300 to 500 feet." And so that's kind of the first tip off. Now, you said a cool foot or leg, and yes, that does happen, but it's usually as things progress that you get. You go from what I just described as claudication being exercise-induced cramping of the musculature,
Okay.
to rest pain. And rest
That's
pain
getting bad.
is when you go to bed at night, you elevate your leg, you don't have gravity help you with the blood flow down to your feet, and now all of a sudden you start getting pain in the leg or the foot because you don't have that gravity to help, and that's called rest pain. And basically what happens is your tissues cannot get enough blood to satisfy their basic metabolic demands. And that's a bad. In fact, we differentiate to a large degree claudication from rest pain. Claudication carries a less than 1% risk of limb loss per year. Rest pain, on the other hand, is about 25%.
So this is high stakes. You could lose a limb.
Yes.
So someone comes to you, now they've got rest pain,
Yes.
Johnny, and you do whatever studies you do, you find that there's some blockage in there. Now, what can you do about that blockage? Can you open it up, or what can you do?
Before I address that and go to what I would consider to be the exciting part of this, let me tell you some boring stuff. And the boring stuff is that when we see patients with claudication, and we see a ton of those patients on a weekly basis, it's a conservative management program. And what I mean by that is we try to correct as many risk factors as we can. Now,
quit smoking, lose weight,
yes,
increase your activity a little bit, or what? Okay.
And our success rate with that is abysmal. I'm
Right,
just going
right.
to tell you, it's
I want a pill.
terrible.
I want a pill.
Because you take a patient who is in a certain culture, lifestyle, grown up for the last 50 years doing things the way they want to do them, and now you tell them that, hey, all this stuff that you've been accustomed to doing, we want you to radically change it. All their friends do it.
Yeah,
their
it's not gonna
coworkers
happen.
do it. It's probably not going to happen, as you said.
Not often.
So then when we see people with rest pain, then we know, okay, we got to do something here. If we don't intervene, then we're going to lose a toe or a foot or a leg.
Yeah.
And unfortunately, that does happen. And so, so intervening, you can divide into two big groups: open interventions, which is what we've done for years and years in vascular surgery. And what I'm alluding to are cleaning out blockages, bypassing blockages. They're the two most common ways that we have to deal with blockages for an open intervention. Or we can do an endovascular intervention. And an endovascular intervention means that we basically can clear the blockage by stenting, or by sucking the blockage out. And I'm using some terms that I think your audience would understand.
Yeah.
We don't technically suck the blockage out. We can use a little roto-rooter and suck out the little particles.
So you've got a roto-rooter that can open that up potentially.
Yes.
Do you ever use those balloons like they do in the heart to push them open?
Absolutely.
And stent. Now a stent is one of these little wire cages, it's all compressed and it springs open.
Yes.
You can put stents in a leg?
Absolutely. So the balloon is called angioplasty, a percutaneous transluminal angioplasty. We can do that through a catheter, and the catheter is about the size of the end of a ballpoint pen. And basically, we introduce a balloon across the blockage. We push the blockage to the side. And mature blockages that we're talking about have usually very little recoil, so we're pretty successful at doing that.
You crack them
It
open.
turns out, yes, and it turns out that some arteries are really good at percutaneous interventions. And when I say good, I mean the 5 year risk of them developing another blockage there or reaccumulating the blockage in the same place is low. And other arteries are just terrible. We just don't do very well at using balloons.
They're just different.
And so, another way to help obviate that low success rate is by putting stents in, which are little wire mesh cages, if you will, to hold the artery open. And again, that works really well in some arteries and doesn't work worth a damn in other arteries.
And that's where you need an experienced surgeon who knows the difference. Now, let's say it's getting really blocked, Johnny, or completely blocked, and now blood is finding other ways around. Blood's trying to go out the little arteries, and they're all damaged and whatnot. Do you do something like an actual bypass of these blockages?
Absolutely.
Would you describe that for me, please?
Okay, so a bypass is really a plumbing problem. I mean, I hate to say it like that, but it really is.
For us to understand.
So let's say that you have a pipe that's completely blocked off. You need good inflow and you need good outflow. And then you need a good conduit around that. And so if you had a pipe in your house that was blocked off and you couldn't access it, or you knew that accessing it and cleaning it out was really not very good, you wanted to bypass it, you would put a piece of pipe from good inflow around the blockage to good outflow. And you would probably tie it in and do it all with a really good conduit, another pipe of the same size or even a little bigger. And that's exactly what we do in vascular surgery. The conduit that we love to use is the patient's vein, the patient's lower extremity saphenous vein. A nice saphenous vein without any blood clots in it of sufficient size is the best conduit that we have for bypass, bar none.
You'd cut it out. You would move it. You'd graft it from one part of the leg, get a good piece of saphenous vein, and transplant it.
Yes, that's exactly what we do.
And the vein will hold the pressure of the artery?
Yes, it will. Yes, it will. And in fact, the saphenous vein, and we're talking about a good saphenous vein that's not varicose. It doesn't have any blood clots in it.
You haven't been in there with lasers and radio frequency, right?
And in fact, that's a question a lot of people ask me. A lot of young people with varicose veins say, well, my saphenous vein, what if I were to need it like Uncle Joe did at the age of 60? And I say, well, your saphenous vein is not of good quality. That's the reason that we're going to laser it, and it wouldn't be of good quality to use for a bypass anyway.
Okay.
But yes, we use the saphenous vein for the bypass. The thought that people had many, many, many years ago that, well, it's thin-walled, it's going to be subjected to pressures much higher than it's used to seeing. Is it going to become larger, dilated, aneurysmal?
Okay.
The answer to that is no. It usually does not. It almost never does. Now, if you have one that's been in place for 20 or 25 years, I've certainly seen aneurysms develop in those. But we're unfortunately, when patients come to us with major blockages, I'm gonna tell you that their 5-year survival from their heart problems and their lung problems and their kidney problems and all the other things that are usually going on with them means that the 5-year survival is about 50 to 60%. And that's pretty harsh to say. And I'm going to say something that's pretty harsh, which is we're not looking for a solution for 20 years. We're looking for a solution for 5 to 10 years.